Thank you, Dr. Ryman, for the kind introduction, and thank you, Astra, for sponsoring this session. I'll try to be brief. I know everyone is tired and hungry and want to eat their dinner. So there is a disclaimer. I was asked to say that these slides are prepared by myself, and AstraZeneca has nothing to do with them. So the first slide is on the triangle study, which was a very well-designed study, trying to answer 3 questions. Does adding a BTK inhibitor like ibrutinib to chemotherapy improve progression-free survival and overall survival? The second question, is it safe to combine it to chemotherapy? And the third question, do we still need autologous transplant in mantle cell lymphoma? And there are 3 groups or 3 groups of patients who had the standard chemotherapy, which is R-CHOP, R-DHAP, followed by autologous transplant, and then rituximab maintenance. The other group is combining ibrutinib with chemotherapy, and then autologous transplant followed by maintenance with ibrutinib. And the third arm was R-CHOP, R-DHAP, and ibrutinib, and no autologous transplant. So what it has shown is that these are the characteristics of the patients. They are equal between all groups. And what it has shown, failure-free survival is good with the 2 groups with ibrutinib compared to the group that is standard of care. So the standard of care is the green line. And it has shown that the efficacy adding ibrutinib is better than the standard of care that we have currently. The next question to answer by this trial is, does having ibrutinib and autologous transplant produce a better failure-free survival? And it is statistically better using ibrutinib with chemotherapy and transplant compared to our standard of care. So you can see the hazard ratio of 0.52. Transplant has been established in mantle cell lymphoma based on 1 trial, and this trial is a very old trial. It was started in 1996, and at that time there was no rituximab. Some of these patients did not receive rituximab. Some of these patients received the transplant. The arm that was compared with transplant was interferon, believe it or not. So they're trying to compare the efficacy of transplant versus interferon. And after 14 years of follow-up, finally overall survival benefit was shown. So you can see that it took a very long time to show that autologous transplant is better than interferon, which is basically placebo. So the role of transplant in mantle cell lymphoma is questionable. And here you see the arm, which is our standard of care, group A, the red line, is not any different from failure-free survival compared to the arm which had ibrutinib and no transplant. So the place for transplant is being challenged with this trial. Do we really still need to transplant if we add a BTK inhibitor to our standard of care chemotherapy? Overall survival is equal between all groups. And from the third question about the toxicity of this combination, there is no signal of increased toxicity adding this. The only signal from increased toxicity is from transplant, and you can see that the transplant adds a significant toxicity to the combination of treatment. So cause of death, you can see that the cause of death is equal between all arms. There is no significant increased death between all the arms. Then we come to the SELENE study, which is they gave the physicians the options of having bendamustine rituximab plus ibrutinib, or CHOP plus ibrutinib. And this study they were trying to say that progression-free survival is actually better using ibrutinib plus chemo than chemo alone. And this study failed to show that. 90% of the patients actually received bendamustine rituximab, while 10% received CHOP chemotherapy. So that was a negative study. The next study, which was trying to show similar ibrutinib plus bendamustine rituximab, this was a positive study in terms of progression-free survival. It has proven the point that adding ibrutinib to bendamustine rituximab improves progression-free survival. However, it did not improve overall survival, and it had significant toxicities, and that has led AbbVie to withdraw the indication for using ibrutinib in mantle cell lymphoma. The toxicities from this combination, pneumonias were 33% versus 23%, diarrhea was 46% versus 36%, rash was 37% versus 21%, and atrial fibrillation was 13.9% versus 6.5%. So significant toxicities adding ibrutinib to bendamustine rituximab. So we move on to a second generation BTK inhibitor, acalabrutinib, and this is a kinogram showing that acalabrutinib is much more selective than ibrutinib. And the next, you can see that the inhibition of these BTK enzymes is not inhibited by acala versus they are being inhibited by ibrutinib. So this study is very similar to the previous study that we just discussed, bendamustine plus ibrutinib. So this is bendamustine plus acalabrutinib. And what it has shown that in acalabrutinib patients in relapse setting, there is some efficacy using acalabrutinib, and this is the CR rates, the orange lines, that there is significant efficacy of acalabrutinib to no treatment. So progression-free survival is improved in those who had CRs. Median progression-free survival is 22 months. The side effect profile is quite reasonable. Infection, grade 2, 3, 4 infections with 10%. Follow-up is reasonable. Blastoid and pleomorphic variants. The study was looking at the acalabrutinib variants of mantle cell lymphoma. This is a group that does usually has a worse prognosis, and they don't do very well. And the median overall survival was 59 months. The duration of response was 28 months. This is the characteristics of this group, and you can see that it is a heavily pretreated group, and it's a group that you would not expect it to do very well. The overall response rate was, as you can see here, 81% in this group. CR rates almost 40% in this difficult group to treat. This is the duration of response curve. Median duration of response is about a bit more than a year. Progression-free survival, 15.2 months of this blastoid pleomorphic variants. And this is the investigator-assessed overall survival curve, which is showing 36.3 months. Zanubrutinib has been also used in relapse refractory mantle cell lymphoma, although the follow-up is still short, but it also has shown benefit using it in mantle cell lymphoma. At a progression-free survival is at 19.1 months, CR rates about 15%, and PR rates 69%, 84% overall response rates. So it's a reasonable, decent outcome in relapse refractory mantle cell lymphoma. This is the complete responses. As you can see, the complete responses in red and the stable disease in green, and it's showing a median duration of response of about 18.5 months, progression-free survival of 21.1 months. Pirtobrutinib is a new non-covalent binding medication used in patients who had 2 lines with covalent BTK inhibitors. So those who are resistant to covalent BTK inhibitors in a phase 1, phase 2 study. It has shown efficacy in mantle cell lymphoma patients. It's a dose escalation study, which has shown that it has an efficacy in those who are BTK inhibitor resistant. This is the progression-free survival of about 5.6 months in heavily pretreated patients, and overall survival, a decent overall survival, median overall survival 23.5 months in those who are refractory to BTK inhibitors. And thank you for listening.